polite and not interrupt, but if you have questions, we should have plenty of time to answer them within the time frame. So just feel free to unmute yourself. So Jeff already shared the learning objectives. I rearranged them slightly to go in the order of how the presentation is going to go. We're going to talk about care plans, determining which spaces are key drivers, how the population projections tie to a project, and then connecting public health data with performance metrics. So in terms of who am I? So I'm an architect, and I have 3 lines here because I've practiced on both coasts and had a 3rd career in the AIA, where I had the privilege of serving with Jeff on the AIA California board. While he was president, I was representing San Francisco. And then in 2010, I left the profession and became an entrepreneur and started a company that was trying to use technology to automate healthcare design. I forgot my little dash. And then in 2018, I went back to traditional practice. Quickly remembered how difficult that was. So I'm an entrepreneur again, and I'm not sure what I'll be next. But I've been doing that over the last 30 years. So I wanted to talk about why we may want to think about changing the way we do things. And I like to say, Houston, we've had a problem. And I know in the movies, it's Houston, we have a problem. I actually did the research, and they actually said we've had a problem because it's been going on a while. And I don't know about you, but most of the healthcare projects I've worked on, there are owner-driven changes before the project opens up that could have been prevented. And I personally feel that that's something that can be looked at and done better if we had the right tools. And that's what I'm hoping to talk about today. So you might be wondering, well, why is this happening? Well, for one, I feel that we look backwards to project the future. So a lot of our clients, or at least the clients that I've had, want to know what everyone else is doing, what have they done before, and they use those metrics to project what they should do in the future. And there's some basic challenges with that. So the first one is our population. So when I was born in the 60s, the average age was 25. Today it's 35. And by the end of the century, it's going to be 45. And in about 9 years, it's going to be the first time in the US history that there are going to be more 65-year-old people and above than there will be 18-year-old people and younger. So it's just reinforcing that we are all getting older. Sorry. So how do we experience healthcare? So when I grew up, I guess I'm so old that we actually still had house calls. Today, we visit doctors in the offices, and in the future, it's definitely going to the internet. But oops. But the reality is the internet has already started, and where healthcare is going to what a lot of medical thinkers are calling a fully distributed care model, which means you could really receive any care anywhere. And then the question is, what's going to happen to our buildings? So again, in the 1960s, the country was really producing children. Today, we're focused more on living. And by the end of the century, we're really going to be focusing on complex ailments, but it's likely going to be sped up, primarily because we're dealing with the pandemic and all of the fallout. There's going to be more chronic diseases. So the example that I like citing is Alzheimer's. Alzheimer's wasn't even found until 1907, and the National Institute of Aging didn't recognize it as a disease until 1977, I believe. So for the last 50 years, we've had this major impact to our healthcare infrastructure. And I believe there's going to be more of it because we're just aging and our body isn't used to living as long. There's going to be medicine that is made in space and below the seas that are going to be transformative. And Elon Musk did not ask me to put this in here, but mind uploading is going to be a form of medicine or in terms of therapy. So what's going to happen at the end of the century is we are going to be dealing with complex ailments, but people are going to be part human and part machine. People are that way now. It's just going to be more so. And research, especially in hospitals, are going to be more prevalent. So I think a lot of you know that the only constant in healthcare is change, but it's really the chance to live. And that's what we need to focus on. And we need to think about the different questions we need to ask. So, excuse misspelling, I just noticed it. For different problems, we need to ask different questions. And we can't leverage our past. And what we really need to focus on is optioneering or optioneers with our client, because a lot of times our client doesn't even know what the answer is and what they want. So what questions should we ask? So many of you know a lot about lean, probably more than me. And it's really looking at what is the root cause of why you're doing this project. And I listed 5 different questions of why maybe we were adding a bed tower, and I couldn't get to the real cause. And you know, essentially, we need more beds. That's what the business case calls for, blah, blah, blah. And the staff thought the initial need wasn't warranted because there wasn't enough staff. And the point here is that they're still not going to provide enough staff, and they're just kicking the can down the road. So unless you can model the healthcare need properly, you're likely not going to be building the right project. So is the problem that we need to solve about capacity, which means, do you have the right number of procedures per year in the building? Or is it about, where's my demand, which is serving the population of so many people having Y diagnosis needing Z treatments? And that's the difference that I'm going to be suggesting today, that we don't focus on capacity, but focus more on the population demand. So again, are we building to a capacity from the past and projecting it forward? Or are we looking at what the population needs to serve a community? So this is a chart from the New England Journal of Medicine that I really like showing. It's doctors looking at an emergency department, the blue line being elective admits from the emergency department, red line being the emergency admits from the department. And as you can see, there's a lot of variation. It doesn't require a degree in statistics to determine that. So the likely outcome that is normally done today is we take the average and we double it. So if you look at the full range, you need a minimum of 59 admit spots, or you could have as many as 134. And what normally gets built is 96, because that's the average. So what happens on the day when you have an average number of beds, but 38 additional admissions? And it causes a lot of stress on the system. And I think we have the tools and the know-how to predict that. So in terms of how is demand thinking different? This is a population pyramid. So there's 2 groups of censuses. The males are the lighter gray, the females are the darker blue, and the highlighted color is showing women that could bear children. And the reason why that's important today is that a lot of healthcare providers see women and moms as being the primary customer to their healthcare system. Well, in 40 years, that's going to change, because we're going to have a lot more older people than we are moms that are producing children. And as I mentioned earlier, there's going to be even younger people than there are older people. And then by 2100, we're actually going to have 20% less women who are fertile to give birth, and we're going to have many, many more older people. So we can't really look at the past to project the future in terms of demand. And I'm not at all suggesting we should build a building for 2,100 today, but we should start thinking about how is that building going to change in the future so the client doesn't have to start from scratch. What about the competition? There's a lot of different competitors out there. I probably should have picked Orange County, I'm sorry, but this is San Francisco, where I'm based out of. So on the doctor's office side, you could see there's One Medical. On the hospital side, you can see there's UCSF. So these are all data points that are going to impact your project and what should or shouldn't go in there. And you might be thinking, well, this isn't really my job. You know, that's the client's job. And I would challenge you to think, when sustainability first started coming around, probably a lot of architects felt like that wasn't my problem. The world is going to just burn up anyway. But the reality is that global warming is a real issue. And what I'm talking about is building the right building. And that is part of the carbon footprint that we all need to start thinking about. So how do we change our thinking to understand how people are cared for? So I'm going to talk about what a care plan is. And the simple definition of a care plan is it's a functional choreography of a patient journey. And what that looks like, this is just a simple example of someone who might have a heart electrical malfunction, which is also called cardiac arrhythmia or conduction disorder. And these are the key spaces that the patient might go to. So they always start out going to see the doctor. They always see the doctor, and they always leave the doctor unless they're going to the hospital. And then while they're at the doctor, they have different experiences in different key spaces, and those become the key drivers. Some are standard and some are less standard, like you might need a pacemaker implanted or replaced. So that's the basis of what a care plan is. So these circular rooms or spaces are what we call key drivers, and they are the main spaces where patients receive or experience care, but they're not what I'll show you next, the derivative spaces like a nurse's station or a storage room, which have to be there, but you don't need to really understand how many there are at this level. So as you're doing a space program, you have these key driver spaces, and then you have the derivative spaces, which are all typically based on rules or logic. I call them allocation rules. And what's interesting is 20%, or in this case, 18% of the area of key drivers really drives 80% of the spaces. So I'm assuming you've heard of the Pareto principle, where 20% of the effort gets you 80% there. It's certainly true with a care plan and understanding what the key drivers are for the different spaces. Now, I think we all lived through the pandemic, and we all experienced how before the pandemic, telehealth wasn't really embraced. And now telehealth is being looked at as, wow, this really works. This can be really helpful. So what this chart shows, the blue is showing 2 exam rooms per doc here, 1 and 2/3, 1.5, 1 and 1/3, 1 exam room per doc, so forth and so on. And the reason why this is relevant is that telehealth impacts the number of exam rooms. And the common belief with telehealth is that at least 1/3 of the patients can be seen over the phone after their first encounter with the doctor as they're doing maintenance. And what you'll see is as the number of exam rooms per doc go from 2 to 1, it's a 300 square foot per MD per 12 doctor clinic reduction, which is pretty significant. So I think you really need to quickly understand what some of the impacts of that may happen as you start using technology. And as it impacts the care plan, so we talked about telehealth. Eventually, a lot of patients are going to have devices at home, and they're not going to need them in the doctor's office. And if they're not at home, they're going to be at the proverbial CVS's or Walmart or Targets, where patients don't have to go to the doctor's office. They'll be able to go get their medical care where they're going shopping. And as a healthcare architect, I think we need to understand what the impact of that is. So looking at cardiology a little bit more broadly, these are some of the major disease types that are considered. So again, these are the basic rooms that we talked about. These are some of the other key drivers we didn't talk about. Some of these key drivers may not be needed for the different diagnoses, but these are the type of questions I believe we need to ask our clients. Do you really need that, or do you foresee not needing that in the future? And these are the specialties that will likely change. So family medicine, internal medicine, gynecology, obstetrics, pediatrics, bariatrics, oncology screening, nephrology, infectious disease, minor physical rehab, and procedural surgery. There's a whole bunch that likely will not change. We're likely going to always have to go to the dentist. We're likely going to always have to go to a center to get oncology treatment. I don't think we're going to be able to get transplants out of the hospital. So we can start segregating where and how we can apply technology and where it's more traditional. So I want to show you a couple examples where we've actually done this. So it's not just me kind of suggesting, oh yeah, this is a better way of doing it. And there's two projects, one in Saudi Arabia and one in China. Most of the projects that we've done in the US, we're not allowed to talk about because we not use publicly available data. Both of these projects, we've used publicly available data, so we're allowed to talk about them. So the first one is for, the acronym is pronounced CAFD, King Abdullah's Financial District. And this was a brand new city near Riyadh, which is the capital of Saudi Arabia, and they had no data. So we had to find a source of information that could work and allow them the infrastructure to support their new city. And what they wanted to do is, I'm missing some text here, so I apologize. What they wanted to do is understand what they needed in terms of the different disease types, how many beds they might have, and then low, medium, and high estimates. Again, we looked at the different care plans for the different diagnoses, and this was more of a orthopedic type of understanding. And what we were able to do is they initially assumed that they needed 3 beds per 1,000, which is what we have here in the US. And we were able to model it to be 1.2 beds per 1,000. So it was a fairly significant savings because we shifted the model of care to an outpatient setting. And this is how we were able to show the quote unquote architecture. They started out with a 50-bed facility, and then as demand growed, they could add 50 more beds, another 50 beds, and then another 150 beds to get to the 300 beds needed. And the savings were more than significant. It's probably the only project that I've worked on where the end cost was less than half of what the initial cost were. So this modeling really, although it took a little bit of time, saves a lot of capital costs. So the next project is the Shantou University Medical Center in Shantou. And cancer is really problematic in India and China. And in China, in the course of this presentation, 360 people are going to be diagnosed with cancer. So as a slide says, 6 people are diagnosed in every minute. So this is where if you build it, people will come, right? There's no shortage of the demand. However, the project was being funded by a business person, and he didn't really understand why the doctors wanted so many different key driver types of spaces. So again, we were able to use population health, created this dashboard where we were able to codify the different oncology types and tie them to the different key driver rooms. So I'm going to show you some studies that we did. So the first one was on surgeries. The first one we did was made their ORs more efficient by having them operate a little bit longer than they initially assumed. So they initially wanted 14. By increasing their efficiency by operating longer and increasing the size of the PACU, we were able to get it down to 10. We also looked at what would happen if they added a Da Vinci robot. And the reason why this is important is this was a study where we ended up not pursuing it because the client didn't want to spend the money for the robot and didn't think culturally it was the right fit for the team. So we're not saying that this will always find the solution, but it's good to look at the different analyses. We did the same thing with radiotherapy machines. So the client, the user initially asked for 11 Linacs. And as many of you know, they're about $10 million each. So the funder pushed back and said, why do you need so many? So we reduced the 11 to 8. And then we looked at, because it is a research campus, what if as they called it, a miracle drug came on the market and reduced the need of radiotherapy? So what we ended up building were actually 8 radiotherapy machines, of which 4 were shelved. We reduced the number of beds and we reduced the number of ORs. And that savings allowed a much larger research building. So even though I've been talking about cost savings, it's really about bringing value to the client. So how do we do all this? I hope you're wondering. So you might be thinking, will I need more than an Excel file or a pivot table? And the answer is maybe, maybe not. But what I've showed you are really 3 domains. The space domain, and I'm sure you all have BIM or CAD packages, and that needs to be connected to a spreadsheet or a database. You need medical information, which is either in a database or a spreadsheet, and use information, which is also in a database or a spreadsheet. And what you may or may not have is what I'm calling a connector. So what a connector is either an agent-based or a discrete event simulator. And the difference in very simple terms is an agent-based allows variation of what the assumptions are, and a discrete event simulator is something more structured and rigid. They're both good modeling tools. One's faster than the other, but they both provide good outcomes. So Excel could do this. I don't want you to think that you have to go out and spend a lot of money on a new software tool if you're interested in doing that. The challenge, of course, is you're going to have to figure out how to get Excel to do that. So we would recommend you either purchase a software that already does that, and I've listed several here, some of which you might have heard. One is the company that I'm I'm currently trying to start. But there's also open source native languages that will do it as well. So you really have a range of options if you think that this is an important way forward for healthcare architecture. Now, if you like this, but you don't want to do it, which is a very common outcome, you can certainly consult with other companies that do this. There are other companies that do this. And you could either do it as a software as a service subscription, or you can do it as a lump sum arrangement. And I believe, I can't speak for competitors, but I know we would either work for an architect or the owner, and I'm sure the same is true for the competitors. So if I interest you to look into this some more, I do need to warn you that there are different types of medical simulation. And the medical simulation with the mannequins is way more popular than the medical simulation for architects. So there's an association of medical simulation and a bunch of other things. Just be careful not to spend too much time on the wrong site when you're doing your research. So we definitely need data. And you might think the owner has all the data that you need. And they absolutely do. The challenge is getting the data. And if you can imagine an architect asking a doctor for clinical information, what the response is, you're probably right. So one of the reasons why we recommend using publicly available data is that it's available, it's trusted, and most of it is free, right? So you can quickly get to answers that you might be looking for. And if the facility doesn't like the answers, then they can give you the data. And that has been our approach with many of the projects that we've been involved in. So the data, again, that you'll need in terms of space data, the BIM or CAD files, owner standards, your own standards. We base a lot of our automation tools on the US Department of Veterans Affairs because they're open source and we could share that information publicly. In terms of medical information, I'll share some sites on the next slide where you can go to. And similarly for use information, so number of people, competition, and staffing. So California is a great place to practice in if you want to do this, primarily because of OSHPD and OSHPD's reporting requirements. So although most of us know OSHPD for Facilities Development Division, if you go to the data and reports section, you'll just find a treasure trove of materials. So they are integrated with the California Health and Human Services portal, and you'll get both the utilization and outcomes. The other two sites is the CDC. The CDC focuses on more ailments and not that are disease specific. And then of course the Census Bureau. So sources, the demand of the medical care would likely come from the Census Bureau. Utilization and performance is going to come from OSHPD and the California Health and Human Services. And the incidence and need will likely come from the Center of Disease Control. So there's different ways to use the data. And you could be looking at a health system analysis. You could be looking at a clinical simulation for a department or a building. You could be looking at, even before the client starts thinking about what they need, how they're going to actually deliver the model of care. Or you could look at, how do I prevent the illnesses that the client wants to treat? So this was a good framework that I found in a white paper that I wanted to share. So I'm suggesting that you take data and model it, and it requires actually a lot of data. And the main message from this slide is that we all think of Revit models as being huge. When you start optimizing and running many scenarios, the optimization model for the Chantal project was 10,000 times the size of our Revit model. So they're really, you're just generating data, and a lot of data may not be valuable, but you have to run the data to see if that scenario is meaningful or not. And that's why you end up generating so much data. You also have the ability to compare quantitatively. So this is a radar chart of several different scenarios overlapping. And you can see how some have more staff, but others have more acute care patient beds. And this is a very good, quick way to look at how your scenarios compare to different designs and or different existing conditions. As I mentioned, you have the ability to share when you use publicly available data. You typically aren't able to share when you're using electronic health records. And I just want to wrap up. So I hope the main message that you got from the presentation is that we need to focus on the problem that needs to be solved first. And I really like this book from AIAOC, written by Bill Penna and Steve Parshall. I think originally it might have been from CRRS, but it really talks about the role of programming and problem seeking. And I think Albert Einstein coins this best by saying, if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem and 5 minutes thinking about the solution. And I feel as architects, we're so solution oriented that we don't spend enough time with the problem to really understand what's best to be solved. Second to last message is technology is only going to give you an answer for what you're really looking for. So I'm sure you've heard of the term garbage in, garbage out. If you're trying to solve the wrong problem, the technology is not going to be able to help you figure that out. And the last thing I want you to do, there's just one more slide, is think about going to the supermarket and thinking about your favorite food that you want to buy. And after you pick it up, you're likely going to smell it. And the next thing you're going to do is look at the nutrition label. And the reason why I'm pointing this out is everyone makes decisions emotionally and we rationalize them logically. And the reason why technology can play an important role is, especially in healthcare, is that we can create data tables for healthcare buildings so that that simple nutritional chart that's on every piece of food that you buy in a supermarket can be on a building, so that a nutrition label or a building data label for healthcare maybe will not look exactly like that, but can be provided so clients can make more rational decisions. So I will stop talking, and I hope someone has a question.
Hey, Zig, it's Meredith. I have a question.
Okay.
Oh, let me get my video. Hi, what do you, oh, well, you guys aren't missing anything. What do you anticipate as being like a completion date for this, when it will be accessible to people?
Oh, you mean the tool that I'm working on?
Yeah. Or
it's likely, so it's accessible now, but I wouldn't say it's functional. Well, it is functional. It's just not all tied together. Definitely early next month.
So if people wanted to use your tool, is there a way that they could use
Yeah,
the tool and then provide you with it? Basically, that would be good feedback to you as well, correct? So
Right,
it could be an
right.
alliance, sort of
Just-
like a
Yeah,
synergistic advantage.
right. Just email me. We are currently letting anyone and everyone use it after a product demo, primarily because it's like a teenager driving a car. You don't give them the keys. You want them to at least see how it's done first.
Right.
So we are happy to let people kick the tires and let us know what they think.
Okay. Cool.
Hi, David. This is Mark Gans. This question actually might be both for you and Meredith in terms of I started thinking about resource allocation during your presentation, which led me back to certificate of need. How far away is Oshpod from on that side of the house that you were talking about from being able to actually make some predictions along the same lines you are? And will that eventually end up back at the CON process?
Yeah, that's a very insightful question. So as you know, California is not a certificate of need state. So if people wanted to, they could have a hospital on every block. But the way our tool works is purely based on population from the census. So the way our tool is set up is, I'm just gonna use some very general numbers. But let's say Orange County has a population of, I don't know, 1.5 million. We would then be able to say you would need X number of beds for these types of services. And then you would be able to say, okay, my facility is going to target 22% of the market. And then you could look at how much the demand is going to grow. So if it's for cardiac services, you're definitely going to have more demand in the future. But if it's for obstetrics, it's likely not going to grow. So I don't know if I answered your question.
So the tool is more aimed at facility by facility or the providers to the public rather than, say, public health database predictions and stuff like that.
No, it can be used for both. The tool works based on public health. So we have all of the disease incidents, and we have the way the population is going to transform. We then are able to predict the number of spaces that are needed based on the population changes. I think what I'm a little bit resistant about, or I'm hesitant about, is we're not going to be able to predict how the health of the public might change. But we are able to predict the spaces that the public might need. Does that make sense?
Yeah, it really does, as a matter of fact. So in terms of another common word phrase that we use is that we provide buildings that provide healthcare. Well, actually, they provide sick care.
Right.
On the other, yeah. So on the other hand, if we could encourage our population to be healthier, more
Right.
time in the gym or better food or stuff like that, is the model sensitive to be able to take those kinds of things into account?
So the short answer is currently no, but in the future, yes. And the project that I showed you for the King Abdullah Financial District, that's exactly what we did. However, we were kind of turning all the knobs and making all the changes. I would say that functionality is probably 6 to 8 months away.
That's really exciting. Thank you so much.
Sure. But that is really where we want to enable the project teams, whether it's the architects or the owners, to look at those what if scenarios and really kind of support what I believe is called salutogenic living, where you're focusing on life and not disease.
So you can start affecting insurance companies' actuarial charts.
Yeah, I can only hope.
Thank you.
This is Meredith again. I just want to tell everybody on this call that Zig is going to be one of our panelists on the Future of Technology panel for the AIA California Healthcare Facility Forum coming up the mornings of September 9th and 10th virtually. And I'm sure he will make it even more interesting.
Well, I don't know about that, but okay.
I do. I'm sure you will. No doubt.
That's going to be amazing. Yeah, and thanks Meredith for actually creating this meeting and, you know, like having this
Sure.
happen.
Yeah.
Thank you.
I'm in awe.
Looking
I'm in
forward to
awe
this.
of Zig's, of what you've come up with. And I think it's just taking the whole planning, you know, what people used to do, creating programs starting from, you know, beds being the driver spaces of a program, to trying to figure out how much outpatient versus inpatient, but always being behind the eight ball, so to speak, you know, always being a little bit behind, to now really trying to evaluate what the impact of technology is going to be so that we can be better planners for a facility which is actually complete, you know, ready to go when the facility is complete is great. It's so important.
Hi, Zig. This is Amy Delson. Good to hear you again and see how
Hi,
you
Amy.
changed over to all the things that you're doing. So I have a question. This is a great talk. So what are you telling your clients about pandemics? So obviously you don't want to build a hospital for a pandemic, but what are you telling them, to kit out their parking garages for the future, or what?
So we actually created a pandemic tool, if that's the right word. And it was based on, it's called the SIR model, susceptibility, incidence, and recovery time. And basically the user could look at the number of beds they're going to need, and if they need to, maybe they're going to run out of beds, and if they needed to decant beds. And to answer your question, most of the clients that we spoke to were just in what I would call damage control phase. And I felt that no matter what we said, they were just trying to survive, because they were really just really outside of their comfort zone. So in terms of answering your question about the next pandemic, which I hope we don't have, but it's likely that we will, I don't think most clients are really preparing for something similar to what happened with COVID-19. They're hoping that it will be contained faster, and that because we really learned a lot about it quickly, I don't think they're really planning for it in such a way. Now, the beauty of our tool is that you could run a scenario, or many scenarios, where the susceptibility rate is really high and the infection rate is really high, and everyone gets sick, and we could model it. I think that's going to be more academic than reality. And I think that's one of the reasons why a lot of clients aren't embracing it. And what I always tell even our clients is that even though the tool will give a correct answer, the human has to decide which correct answer they want to live with. So we give a range of options that we'll stand behind, but we don't know what the right best option is for them. And that is definitely true for a pandemic. So I don't know, Amy, if I danced around the answer enough, but it was a good curveball.
Right. There's just always the issue that what if you got it wrong, you know, and then how you don't have enough beds in the system or something. And actually, it turns out that women have children till they're 50, you know, or whatever.
Right. So
To be
yeah,
too
so
tight, too tight a fit.
yeah. So what's interesting about the birthing numbers, I actually included women up to 54, because I know that they are likely gonna have more women have older moms give birth. But what is also going on is that less women are choosing to have children. So it's a very complex problem that is hard to predict. So,
Thank you.
sure.
This is Mark again. Another question in terms of, so in that one example you gave, there ended up being pharmacological solutions rather than physical
Right.
hospital solutions, which starts driving into, is your data going to NIH and telling them what types of grants to be funding for research and study at our universities in terms of how many more labs do we need in the United States to be able to tackle all of our future health problems?
Well, we're just a little fly on the elephant, and we're hoping to survive. When we get bigger and more successful, I think that is a beautiful idea. But I will say that before the pandemic happened, I connected with the CDC, and I thought this would be a great tool for them to use and to model. And they said, well, what would you model? And we came up with this idea of anti-vaxxers. So in the Bay Area, there are a lot of people that don't believe in standard vaccinations. And it's not as much of a problem when they're younger. It's a much bigger problem when they're older, and how that would impact the system. And we went back to the CDC, and that unfortunately was right when COVID was hitting. So understandably, they had their hands full, but it's those kinds of analyses that can be done with a tool like this.
Thank you.
All right. I know I'm in between everyone's dinner or late night events, so I'll say thank you very much for the opportunity to present. And Nilu, I'll share a PDF with you after the call, and hope I get to see everyone in person one of these days soon.
Thank you so much, Zig. That's great.
Sure.
Fascinating.
I can't wait to see everyone in person.
Yeah.
I know. Yeah, you should.
And don't forget, everyone, fill out that Google Doc, please.
Oh yeah, if you want your credit, do that. I know you
Okay.
need your units. It's August.
Hey, Zig, just
Yeah.
one last question before we go. If you were going to say this is the one thing that is going to change the future of healthcare delivery and our facilities, you know, say in the next 10 years, what would you say it is? Okay, the next two things, the greatest two things, because one's too hard.
I'm laughing because I had this conversation with a doctor.
Matt, I see you laughing.
And he's a, you know, well-respected researcher at UCSF.
Uh-huh.
And his opinion, and the reason why I'm laughing, is reimbursement structure.
Ah. Uh-huh.
And the one story that I'll share that he shared with me was when telehealth first started being deployed, they being UCSF weren't even sure how to do it. They were booking rooms for their clinicians to see patients, even though the doctors were in their office. And my friend was like, no, we don't need that. That's the whole point of telehealth. You leave the room empty. So I think the biggest thing that is gonna change or needs to change is this notion of reimbursement. And then the other thing is going to be what I would call the retailization of healthcare to maybe they're the big box stores or the home. So we all, more and more people are able to live longer lives that have chronic diseases. And I think it's just going to get better and better, and they're not going to need to go into healthcare facilities. And I do think that's happening like as we speak.
And that would apply to the elderly beyond octogenarians, but the centenarians as well.
Absolutely. And I don't know if many of you have seen what's going on in Japan. But Japan has a really big problem with an older population compared to the younger population. Problem meaning they just don't have enough young people. And they are really investing in robotics. And my guess is once they figure that out, that is going to be exportable to different areas. And I think we're going to see more robotics cohabitating with older people. So
robotic caregivers.
Yeah, I mean, I don't have an Alexa, but some people can't live without their Alexa because that's how they stay connected. And it's just another source of socialization with technology.
And my last question, I'm sorry to keep everybody, but what are your projections showing for average lifespan increases in the next 10 to 20 years? What are you showing as the average age, at least in the US, for men and women? Do you have that data?
So I don't have it off the top of my head, but if you look at today, it's 35, and in 2100, it's going to be 45.
Lifespan, actual lifespan.
Oh, I'm sorry.
That's okay. Because I know it's gone down a couple of years because of COVID.
Right.
But, do you know what the numbers are for length? I guess, yeah.
I don't, but I do know that they are expecting people to live well into their 120s or 130s by the end of the century. So, you know, that funny commercial by, I think it was Charles Schwab, we're planning the retirement for our first person that's 150 years old. I mean, I think that is really gonna happen one of these days.
Mm-hmm. I hope it's not me. Okay.
Well, I hope it's my children, but not me.
Yeah, exactly. Yeah. Oh.
Okay.
Thank you so much. Thank you.
Thank you so much. Have a great day.
Thank you. Everybody come to the
Thank
Healthcare
you.
Facilities Forum virtual. See you there. Thank you.
Thank you.
Thanks. Take care.
Bye.
Bye, guys.
Thanks.
Thanks all.
Thank you.